Good afternoon, everyone, and thank you so much to the Georgia Women's Commission for the chance to be with all of you today. My name is Nakita Machado. I'm an endocrine surgeon at the Northeast Georgia Medical Center in Gainesville and one of the associate program directors for our general surgery residency. I'm really excited today to get the chance to talk to you about a condition that's not only personally and professionally relevant to me, but that I know for a fact affects women all over the state of Georgia, the country, and then worldwide. We're going to be peeling back the curtain today on parathyroid disease and everything that entails. So I think it's always important when we start to talk about the why. And I would love for everyone to know that there is this condition out there with very nebulous, very varied symptoms. We're talking things like bone loss, like fatigue, like memory issues. And so many times it's missed for months to years on end in women like you and me. I also personally think that nothing tells a story better than a person. And so I'd love for you all to meet Sarah. Her name has been changed for obvious reasons, but she is a patient of mine who I met for the first time 8 to 9 months ago. And her story of presentation, diagnosis, and then just the change in her life after treatment is really why we're all here and why we're talking about this today. Now, like any true endocrine surgeon, I would want to start by talking about perfect balance. The parathyroid glands, when they work correctly, which thankfully they do in most of us, are part of this incredible symphony between your brain, your parathyroid glands, your bones, and kidneys. And if you look at the screen, you'll see that your parathyroid glands are actually really tiny. They're the size of a grain of rice or a corn kernel, and they sit tucked away behind your thyroid gland. There are four of them, and they work together in concert to keep your calcium level in that perfect range. The way they do this is by interacting with other areas of your body. For example, the bones. And so, let's say you wake up one morning and your calcium's lower than it should be. They draw calcium out of the bones to put it back into the bloodstream where it belongs. Let's say you wake up on a different day and your calcium is much higher than it should be. The parathyroid glands shut down and they allow your kidneys to take their time to pee all of that extra calcium out, perfectly maintaining you in that area that we call homeostasis. And like I said, when things work the way that they're supposed to, everything is perfect. But we're not talking about perfect today. We're talking about what happens when things go wrong. And this brings us to hyperparathyroidism. In effect, it's basically a condition where your parathyroid hormone levels are higher than they should be, and that has a ton of downstream effects on multiple systems in your body. There are different kinds of hyperparathyroidism, but for the purpose of the talk today, we're going to be focusing on the most common kind, which is primary. And that essentially means that there is a problem with your parathyroid glands. They're overactive for one reason or another, and most of the time it comes from a benign tumor in one or more of your parathyroid glands. And 85 to 90% of the time, this is a one gland problem and it's easily fixed. And then all your numbers will come back down to normal once the problem is taken care of. Ultimately, though, any condition where you have too much parathyroid hormone in your system can lead to an elevated level of calcium in your blood, what we call hypercalcemia. And it's this hypercalcemia that drives a lot of the symptoms that we will be talking about. The next obvious segue from that is okay, so we know what hyperparathyroidism is, but am I at risk or is anyone that I know? And the answer is it's more common than you would think. We talk about how almost 100,000 new cases of hyperparathyroidism are diagnosed every single year in the US. And as you can clearly see here, the reason that I'm bringing this up at the Women's Commission is that there's a clear skew towards female. The percentage of patients who are female with hyperparathyroidism is almost 60% to 40% for males. The other thing, too, that it's important to note is that primary hyperparathyroidism disproportionately affects older patients. And while I fully realize that 60 to 80 is still considered middle age, the moment you are over the age of 50, you are usually at a higher risk for hyperparathyroidism. One of the main reasons for that is that time in our life of perimenopause and postmenopause. And with a number of other factors that play into it, women who are postmenopausal are at a higher risk of PHPT. It's very important to note, though, that we don't want this to blind us to the fact that this can happen anytime. I have operated on a 25-year-old woman with hyperparathyroidism. I have operated on an 89-year-old with the same disease. So while it's important for us to know these statistics, it's also important to know that those are just statistics. And individual people, it's always 100 or one. I would like to take this time to do away with some of the myths that surround hyperparathyroidism for those of you that know about it. One thing that we get told all the time is that only older women get hyperpara, and we know for a fact that that's not true, just like we talked about. You could be a younger woman, you could be a man, and you could be a child sometimes with genetic syndromes. You can all have hyperparathyroidism. The other thing that I hear about more often than not is we talk about how it's only patients with a really, really high calcium who are in trouble, who need surgery, who need intervention. And that's really not true because the level of your calcium, while it can sometimes indicate severity, is not always accurate. And so you may have a person whose calcium is only mildly elevated above normal. They could still have a whole host and slew of symptoms from hyperpara that it's important to treat. It's also good to know that hyperparathyroidism has a safe and easy way to treat it if it's done in expert hands. And this is curative, hopefully, and essentially lifelong. Ultimately, it's also important, I think, critical for us to talk about the fact that it's not one size fits all. And so patients with hyperparathyroidism can present in a myriad of ways, some of which we're going to talk about next. And as we start to draw those parallels and look at this disease better, we'll realize that it affects probably a lot more people than we know. So, Sarah here is going to talk us through what possible symptoms you could have if you have hyperparathyroidism. And I will say that the real life Sarah had probably about 5 or 6 of these. The most obvious ones, and I think the easiest ones to pinpoint back to hyperparathyroidism, are things like kidney stones or fractures. For patients that have so much calcium in their blood, they don't know what to do with it, the kidneys start to work overtime. And so it's not uncommon for patients to precipitate that calcium in their kidneys and have kidney stones. It also means that you're getting up multiple times at night to go to the bathroom, again, because your kidneys are overworking, and that can lead to this phenomenon of frequent urination. Some of the other symptoms are a little more vague. Patients complain of fatigue, they complain of generalized aches and pains that maybe they didn't have before. Some patients may notice muscle weakness, others may notice constipation. I've even had a patient come in with pancreatitis because their calcium was so high, and that is an extremely rare cause of pancreatitis. The other thing that's a little bit harder to pinpoint is I've had men and women come into my office complain of what they call brain fog. It's this condition where things just feel a little bit cloudier than they used to. And so remembering facts takes just a little bit longer. You walk into a room and you're not exactly sure what you're doing there. And a lot of times it gets attributed to, oh, I'm getting older, which is such a sad thing for me to hear because it's not you. There is a very clear organic reason why this is happening to you, and there's a way for us to fix it. One of the other reasons that I get patients come in to see me is because they get bone density scans. And this is vital once you cross a certain age, because we want to make sure that your bones are healthy. And if there's anything that we can do to prevent them from getting worse or weaker, then we want to do that as early as possible. Now, I've listed a lot of symptoms, and I think it is good to know that the vast majority of people will have symptoms of hyperparathyroidism. We're talking 80 to 85%. You may not have all, you may have one or two, or in some cases, you may have 6, 7, or 8 complaints, but they're there. And so it's important if you see any of these findings or features or concerns that you bring it up because that might just be all that it takes for your physician or your provider to do some additional testing and figure out if you really do have hyperparathyroidism or not. The remaining 15% are where it can sometimes get trickier. These are patients that will sometimes get sent to me because it was found completely incidentally on blood work. Their primary care physician, being very diligent, ordered their yearly blood work and then found an elevated calcium without a great reason to explain it. No medications, nothing that would otherwise lean towards hypercalcemia. And then as secondary testing, they find these abnormal labs and then send them my way. You may think that they're asymptomatic, but when you dig a little deeper and ask them questions, a lot of times you'll find that maybe they do have silent kidney stones, or maybe they even have bone loss that's mild on a bone density scan that was sort of brushed aside because they were otherwise doing really well. And the thought was we would just keep an eye on it. So you've been to your primary care doctor. They've seen this elevated calcium. The question is, what happens next? Primary hyperparathyroidism is diagnosed with a number of different methods, and we'll talk about them now. The main diagnosis is blood tests. And so, very often, when you show up with an elevated calcium, the next few tests that are going to be ordered all follow a pattern. We'll check a parathyroid hormone level to see is it elevated or is it just higher than it should be for where your calcium is. We check a vitamin D level because just like the parathyroid glands, the kidneys, and the bones all interact, so do your hormones at the cellular level. And so your vitamin D, your calcium, your parathyroid hormone, they interact with each other too to maintain that homeostasis that we talked about. We want to make sure that your kidneys are okay. And so we will check a creatinine level on you. And like we had talked about before, one of the hallmarks of hyperparathyroidism is that your kidneys are overworked and they're trying to pee all that calcium out. And so, a great test to do is to just see how much calcium that is over a 24-hour period. If it's past a certain threshold, we know that you are now at risk for kidney stones and everything that follows that. And so, this in itself can sometimes be an indication to intervene. Bone density scans or DEXA scans are great because they tell us where your bones are in terms of health and then how far we have to go before that problem becomes irreversible. Once we've had this initial testing, they usually will end up in my office. And sometimes a primary care doctor will just see an elevated calcium and PTH and send them my way because the testing after that can sometimes vary based on surgeon. And so it's helpful to have them see us sooner rather than later. I will often do two things. We'll do an ultrasound in the office, which is helpful not just to see what your parathyroids look like, but to see what your thyroid looks like. Are there nodules? Is it enlarged? Does it look irritated and hypervascular compared to a normal thyroid? And then a test that I absolutely love is something called a parathyroid 4D CT. It's a CT with really fine cuts and IV contrast that helps us to look at really fine, small glands like your parathyroid glands. And I would say there's about a 95% accuracy for patients that have one single and large gland. And so it's a great test. There are other options, and this could include something like a nuclear medicine scan. And I often will use those if your initial testing is equivocal and we're trying to get a sense of where the best place would be to start in the operating room. Now, I've just told you about this battery of testing that is available. And despite that, hyperparathyroidism is often missed. And so the next question I get asked is why? It is one of those things that has multiple factors that go into it. And I think it's important to know that it's not just a provider or a patient or a lab test, but a confluence of things that can lead to that sometimes. I want to draw your attention to this particular test here, which was actually a study carried out in a large integrated health system in Arkansas. They looked at their own data going back years and found that over 50% of patients with chronic hypercalcemia were not being evaluated for hyperparathyroidism. And out of those patients who met criteria, maybe one third were unrecognized, and 25% of them had gone on to receive treatment. You very well might ask why that is. And I think there's a lot of things that add to that. Number one, remember we had talked about that 15% of patients were asymptomatic? So sometimes when you have an elevated calcium, but you're otherwise doing okay and it flagged on a blood test or two, it doesn't always lead to further testing because in a lot of minds, it's not bothering you. Another thing is it is hard to do routine screening because, like I said, there's plenty of reasons why your calcium might be elevated. And so it's important to look at that in context and to talk to your primary care doctor about that. Finally, with the absolute vagueness and nebulousness of these symptoms, they get attributed to other things, not just by patients, but by providers. And we say, oh, maybe you're tired from XYZ reason. Maybe you've been going to the bathroom so much because you have stress incontinence. Maybe you're on a diuretic. And there's a lot of reasons why these things can overlap. All this to say, it can sometimes take 3 to 5 years to get a diagnosis. And this is something that I would love for it to change. We're even starting to do this now, looking at our own data at Northeast Georgia Medical Center. And we're hoping to find a way to automate some of this testing to minimize the necessity that a single person, provider or patient, would be able to catch this, but that it's built into the system as a safety net. Now, it's not just enough to say, how are we diagnosing it or why are we missing it? But the question is, let's say we do find it. How can this disease process impact women and what does it mean to treat it? One of the biggest things that doesn't get talked about enough is quality of life. It doesn't just matter that you have a disease. What matters is how that disease affects your day to day. And we have found across the board that primary hyperparathyroidism significantly changes your quality of life for a number of reasons, not just the symptoms, but then your increased risk of disability and premature death. And a lot of that comes down to bone disease, and potentially now we're finding cardiovascular disease. Calcium in high doses anywhere in your body is not a good thing. The second thing, too, and I think we talk about this less, is that even though there's not great studies in the US looking at cost analysis, there is a hidden cost to every medical issue. And even things like kidney stones and fractures and bone weakness that lead to hospitalization and rehab and all of the care that that involves, they contribute to significantly increased healthcare expenditure for the patients, for their loved ones, for the health systems that treat them. So it's almost in everyone's best interest to find this early and treat it before it gets to that point. Now, if you take away nothing else from this 30 minutes, this is the slide that I would love for you to focus on because the importance and the correlation of hyperparathyroidism and bone disease cannot be overstressed. When you get a DEXA scan or a bone density scan, one of three things may happen. They may tell you that your bone density is normal, in which case, fantastic. They may tell you that you have something called osteopenia, which is sort of this a gray reversible zone between a normal bone density and osteoporosis. This is, in my opinion, the perfect time to intervene because you can give patients normal bone density back if you get to this early enough. Once we've progressed to osteoporosis, we're at the point where it's not really completely reversible anymore. That being said, you can improve bone density and you can definitely prevent things from getting worse. One of the things that I worry about, especially in postmenopausal women, is this concept of fragility fractures. And it's just like it sounds. It's when you get fractures from a trauma or an impact that would not otherwise cause a fracture in a healthy person. But the bones are so weak that even that minimal impact is enough to do that. And like I said, postmenopausal women are particularly vulnerable to this. Part of the reason why is because estrogen levels go down as we age, and estrogen has a very protective effect on your bone. Add that to the fact that you get put on more and more medications, usually the older you get, and those medications have side effects that interact with each other. Things like steroids can even cause weakening of your bones over time. But all hope is not lost. Studies show that when a parathyroidectomy is performed, we see an improvement in that bone mineral density by up to 12% in a year. And that's fantastic because this leads to reduced fracture risks, reduced disability, and everything that follows after that. In fact, it's one of the reasons why the Endocrine Society and the National Institute of Health recommend surgery for patients with osteoporosis because they realize the importance of this. If you have a fragility fracture, you've ever had one, it doesn't even matter what your calcium level is at that point, you would benefit from an intervention. Now, bone density being one thing, but there's myriad benefits to treating hyperpara. And you can see some of them here. We've talked about how your kidneys really take a beating when you have hyperparathyroidism. This leads to decreased incidence of kidney stones, improves kidney function over time, and again, I think improves longevity. For those people that are complaining of mental fogginess, cloudiness, and just feeling slower in general, this alleviates a ton of those symptoms. I even had a patient who was diagnosed with depression and on medication for that without a good reason really as to why. And then when she came to see me, we found that she had hyperparathyroidism. We treated her with a parathyroidectomy, and I saw her back at 2 weeks. She said it was like someone had turned a light switch off in her head when she had the disease, and that light switch had now been flipped on post parathyroidectomy, which was so gratifying to hear. In general, we talk about how patients will have an overall improvement in their quality of life for a number of things, and that even includes their day to day function after surgery. Now, being a surgeon, I have to talk about parathyroidectomies for the cure. It is honestly the treatment of choice in primary hyperparathyroidism. There is not a medication that works that well. There is a medication that is considered to be an antagonist to the parathyroid hormone, but it's FDA approved for use really in secondary or kidney based hyperparathyroidism. A lot of side effects can come from that medication. And when we have an option that is safe and minimally invasive and can treat the problem, that usually is our go to. Now, you'll see a picture on the bottom of the screen, which is from one of my colleagues at Columbia in New York, and you can see that that incision is almost barely noticeable 3 to 6 months out. That is the goal. We don't want patients to worry about scarring and this large incision across their neck, which is probably how it was done back in the day. We've moved now to more focused techniques for parathyroidectomy, and with that comes scarring that heals to almost invisible depths when we're at that 6-month mark. We don't want you to be able to see it. We don't want you to worry about it. And there are things that we can do to help that along. One of the most amazing things in my mind about a parathyroidectomy is it has minimal downtime. It's an outpatient surgical procedure that usually takes us about 60 to 90 minutes, including anesthesia and running blood work. And one of the most amazing things about it is how quickly your hormone levels drop when you've treated the problem. What I mean by that is when we take out the abnormal gland in the operating room, while patients are still sleeping, we are checking hormone levels on them. And so if you start with a parathyroid hormone level that is 2 to 3 times normal, by the time you wake up, it is back down to the normal range, which means that your calcium normalizes within the next 24 to 48 hours. And the vast majority of patients will see resolution of their symptoms within a matter of days to weeks. And I think that's pretty fantastic. So, does everyone get surgery? Is the next question. And the answer is not really. We do realize that there is a very early cohort of patients where the symptoms and the lab values aren't bad enough to recommend something as invasive as an operation. But I think it's never too early to see an endocrinologist or a surgeon because this is a decision that has to be made with the patient's best interest in heart and with their input. So it's oftentimes a multidisciplinary discussion between your primary care doctor, your endocrinologist, and your endocrine surgeon, in addition to what the patient wants and do they think that this is going to benefit them compared to what they're going through at the moment. I will say that all symptomatic patients are offered surgery. Younger patients who are under the age of 50 are also offered surgery. And the reason for that is the hope is that they have long lives ahead of them, and we would like to minimize the morbidity on them as much as possible. In addition, I sometimes see patients who don't want surveillance. They would like this treated and they would like this treated now. And that's reasonable as long as we talk about the risks and benefits. Things can sometimes get tricky when you have asymptomatic patients because then we're looking at other factors. Like, do they have any objective findings, any lab values that would drive us to say, well, you may not have symptoms now, but we're not that far away from that happening? And as you can see here, that can apply to things like an elevated calcium, a cutoff to where they're excreting a ton of calcium in their urine, kidney stones, or even a reduced kidney function. And any of those things would be a reason to offer them an operation. So, coming back to Sarah, when I first saw her 8 to 9 months ago in clinic, she talked about a few things, and a few of them struck with me so much that they're in my notes and I pulled them for the presentation today. She was in her late 40s and had 3 kids, extremely busy go getter woman who worked at work, she worked at home. And so it's reasonable, I think, for her to think, well, I'm just tired because I'm tired. I have so many things going on. But she started to say a few things that stuck. Number one, she said, I wake up at 8 o'clock and by noon, I'm ready for another nap. This is on weekends. This is when my husband's taking care of the kids, and I still feel like I have no energy. Then she said, sometimes I'll walk into a room to pick something up, to grab a piece of paper or a grocery list. She's like, then I can't just remember why I walked into that room in the first place. And my memory used to be so sharp. And this was a huge change for her. She did mention that she has to get up multiple times at night to pee. We're talking 5 to 6 times. And everyone can imagine how much havoc this would wreak on your sleep cycle and then just your energy levels in general. But the thing that struck with me is that she said that I haven't felt like myself in years. Whatever that version of her was that she was used to, it had faded over the past 2 to 3 years. So we talked. We got all of the testing that we've gone over recently. She had a significantly elevated parathyroid hormone level. Her calcium level was also elevated above normal, maybe not by much. And on the CT scan that we talked about, she had this large candidate lesion on one side behind the left of her thyroid. So we came together, we discussed results, and her and I agreed that the best plan would be to offer her surgery. We took her to the operating room. The surgery took maybe 75 minutes that day, including all the blood work. And as we talked about before, her hormone levels normalized in the operating room. She spent maybe an hour and a half in recovery, went home the same day. But the most amazing part was when she walked into the office 2 weeks later and she said, I feel like me again. And I thought that was incredible. because to be able to give that quality of life back to someone, I mean, I think that's why we do what we do. So, what can you do? What can the rest of us do as we try and raise awareness and advocate for this condition? Number one, I think, is to know yourself and to know your own medical history. It's easier now in the world of EMRs and patient messages. Sometimes it can feel like a lot, but I think going back and looking at your own calcium levels over the past few years, where have they been? Are they in the normal range? If you've ever had a bone density test, is it normal? Has it changed if you've had repeated tests? Is it getting better or worse? Are you on treatment for osteopenia or osteoporosis? And then think about the checklist of symptoms we talked about. Does anything sound like it could apply to you? If any of that is true, the next step is to discuss this with your doctor, with your provider, and discuss your concerns with them. Oftentimes, if you bring this to their attention, even if it's something that you haven't talked about before, that's all it takes to spark further testing and evaluation and make sure that we're not missing something like hyperpara, which is so treatable. And another part, and I think the most important part, I am talking to the Georgia Women's Commission. I think telling other people around you that may not know about hyperparathyroidism, just spreading the word and letting them know what it looks like, how it can affect patients, and how it can affect women so that they are more aware and look at their history a little bit closer, I think can work wonders. So, that being said, there are a lot of resources out there on the internet. There's a lot of information. I think it's important to look for the good sources. So, what I've included here in this QR code is based on the American Association of Endocrine Surgeons. It's a society that I belong to. And their goal is to make sure that we educate providers, patients, and everybody in between. So, this is their information on primary hyperparathyroidism. Take a look. You'll see a lot of useful information there, and feel free to share it with anyone that you think might benefit from it. Also, I know we're doing this talk in June, but July is officially Parathyroid Awareness Month, and it's not that far away. So I think it would be great to be able to spread the word then, encourage calcium checks, have people look at their bone densities, and just in general, maybe raise awareness about this condition that's been hidden behind this veil for so long to see if we can treat this and treat it well. It's also important when you start looking for people to help you along the journey to look for those that do this often. There are some fantastic primary care doctors out there, and they will usually do this initial workup and send you to an endocrinologist who specializes in the condition more. They will then send you to a surgeon to help treat this condition for you. It's important to look for someone that does this either most of the time or all the time. And so high volume surgeons will do at least 100 of these a year. Both the American Association of Endocrine Surgeons, as well as the Association of Head and Neck Surgeons, almost two arms of the same side, have surgeon finders to help you find people in your area that do this often and do it well. It's important because outcomes are better, recurrence rates are lower, so the chance that you'll need a second operation down the road go down. And they have very strict metrics for quality to make sure that patients are well taken care of. On that note, thank you so much for the chance to be with you today and to talk with you. I truly am a nerd for all things endocrine, so you'll see my information here. Like I said, I'm an endocrine surgeon at Northeast Georgia Medical Center in Gainesville. Feel free to reach out if it's medical questions, if it's just that you want to talk about all things endocrine or you want to collaborate on research. I would love to be involved. That's my direct extension of the office that you can reach me at. This is my email address. And thank you so much for the privilege and opportunity to talk with you all today. Thank you.